Okay. So now we do the eye with good old Mike from Monster Z. All right. Here we go. All right. Just some basic stuff. Ophthalmology, study the eye. These are some basic terms that we'll be using throughout the whole PowerPoint presentation. So I might as well just define them right now. You probably know what these are, but here's the medical terms for them, or the anatomical terms that you'll probably need to know. The eyeball is known as the globe. Okay. The orbit is where is the bony structure, the bony area where this globe or the eyeball goes in. Okay. Then we have the eyelids and lashes. They're going to be there to protect the globe or the eyeball. The palpable fissure, okay, is when you close your eye, that slit that you see with the two eyelids. Okay, call that the palpable fissure. The sclera is the white of the eye. The iris is the colored portion of the eye, which is actually a muscle, and we'll get into that. The pupil is not a black dot, it actually is a hole that you could actually put a light into, or let's say an ophthalmoscope. The doctor will look through an ophthalmoscope and it looks right through there to the back of the eye, which is your retina. Okay? And then we have the cornea, which is an extension of the sclera, the white part, but it gets really thin and it goes over the iris and the pupil and then goes back to the sclera. So the cornea and the sclera are really attached to each other. We'll talk about that. Okay? So these are just some basic terms that we'll be utilizing for the rest of the PowerPoint. We also have Opium Glands. These are sebaceous glands that are located on the edges of your eyelids. They're there that they're going to secrete oils so that when we have tears, and we always have tears there to keep your globe moist, what's going to happen is we want to make sure that those tears stay over the globe of the eye. So you're going to have some oil that's going to be secreted on the edges of the eyes to like repel the water, to make sure that the water stays in that area. Okay? We also have the conjunctiva. If you take your eyelid and you pull down over here, that pink area underneath the globe is known as the conjunctiva. Conjunctiva. So that's what that is. It also traps particles so that it doesn't go into your eye. Okay. So here's a picture of the eye, right? Just a few things. There's your sclera, the white part of the eye. This is your pupil. Here's the iris, which is really a muscle. Okay. And we talked about the muscle briefly when we did the autonomic nervous system. How we have radial and circular muscles that make up the iris of the eye. The sclera, the white part, is going to get very thin and is going to cover the iris and the pupil and then come back over here as sclera. That clear area going over the iris and pupil is called the cornea. Okay? The iris kind of works like a, you know, we've talked about the iris of a microscope or diaphragm of a microscope. It gets smaller, it gets bigger, allowing more light to come in or less light to come in. And it's controlled by cranial nerve 3, the ocular motor nerve that's going to do that. Okay? We already talked about how that happens with the sympathetic nervous system and the parasympathetic nervous system. Again, the way it is that you have radial, the radial muscles around here and the circular muscles around here. The parasympathetics control the circular muscles. So when the parasympathetics kick in, the circular muscles are going to tighten like a sphincter and the pupil itself becomes smaller. When the sympathetics kick in, they control the radial muscles, and as these radial muscles shorten, they're going to get shortened, and it's going to make the pupil become bigger. And I showed you that on my little art therapy on the board when we did autonomic nervous system. But that should be all review for you guys. Okay? Questions about circular versus radial muscles in conjunction with the autonomic nervous system? Cats are a little bit different because their eyes are not, their pupils are not round. I don't know exactly, I don't know much about veterinarian stuff, but cat eyes have that diamond, you know, that, you know, if we're like this kind of thing. Cats are more, I mean, I gotta look at it, but cats are more, I guess, like this. So I'm not too sure how that works. Goats are kind of weird too. Have anyone seen goat's eyes? Goat's eyes, if I remember, they're more or less, kind of does that kind of thing, right? Some kind of like two, maybe it's going vertical. I don't know, but it's, they're kind of odd too, and I don't know the rationale why that happens. But I would imagine it still works the same way with sympathetics and parasympathetics. It just, they have different muscles creating those different types of shapes of the iris. Okay? So this is a nice close-up of it. All right? There's the circular muscles, and then out here would be the radial muscles. That's a nice picture to put on your fireplace mantle. Good conversation piece. Okay? All right, the lacrimal apparatus. The word lacrimal, where else have you seen lacrimal from? Yeah, the bone, see? It works. The lacrimal is located in the socket of where the eye is usually sitting. Lacrimal means tears. And that's exactly where the lacrimal bone is, in that area where tears would tend to go towards. So what happens here with the lacrimal gland, now here's the nose over here. So the lacrimal gland is temporal, not nasal. Does that make sense? Temporal because it's closer to the temporal bone. Nasal if it would be closer to the nasal bone. So we'll use those terms nasal and temporal often when we deal with the eyes. You have the lacrimal gland that's over here, and it's going to produce those tears. As the tears go this way, the water goes this way, it's going to ride along the whole area of the eye, and then it goes down into this punctum, which leads to the lacrimal canal, and it dumps out in the inferior concha meatus, inside the nose. Okay, so that's why when you're when you cry, your nose is running, because all those tears, there's so much tears that are being produced. Sure, it's all going to come out this way, but a lot of it's going to go down into the nose and enter the or exit out the inferior concha meatus. Okay, at least the opening underneath there. Okay. Questions about that? All right. Now let's talk about the layers of the eyeball. There's 3 layers. The outer layer we talked about briefly. The sclera, which is the white of the eye, it gets very thin and it covers the iris and the pupil, and it's known as the cornea. That's all one layer. The middle layer is going to be more of the muscular area, and that's going to have what we call the choroid, ciliary bodies, and it connects to the iris. And I'm going to show you pictures of this, it'll make sense. The innermost part of the eye is the retina, which is going to contain all the nerves that connect to your optic nerve. Okay? There isn't much to say about the sclera and the cornea, so let's go right to the middle layer, because that has a little bit more. And I'll show you pictures of all 3 layers too. The choroid is a layer of blood vessels inside the eyeball. Okay? Then we have the ciliary body. The choroid goes all around the eye, and then it thickens when it gets closer to the anterior portion of the eye. This is becoming a little bit more muscular. And this is attached all around the lens of the eye. We'll talk about the lens. Around the lens of the eye, and it has these ligaments that actually attach to the lens. The lens is, it more or less, look at a side view of the lens, it's kind of shaped like that. And then we have a ciliary body that's going to go, and you got to think 3-dimensionally on this. The ciliary body goes around the lens, so it's coming out of the board into the board. Does that make sense? I'm making a cut that's going, a sagittal cut through the eye. All right, so he's looking out that way. And this is where the retina is on this side. Does that make sense? Okay? So you have this ciliary body that's over here that is going to kind of go this way and attach to the choroid area back here, going that way. Are you starting to see what I'm trying to draw there? Okay. What happens here is that there's going to be ligaments that are going to attach to this lens. This lens could stretch and get thinner or could get thicker. That lens getting thicker and thinner is going to make you focus on things that are very far and things that are very close. The ciliary bodies is going to control how dense or how not dense that lens is going to be. Okay? There is a finger of this ciliary body that comes up like this. It comes down like this. This part here is going to be the iris. And again, it's going to go all around here. That's the part that's going to, it's connected to the autonomic nervous system and is going to make it go contract or not. Allowing the pupil, which is this area here, is your pupil. Are you getting to see the picture how I'm doing this? Okay? The uvea is the middle layer. It's really the choroid, the ciliary body, and iris. You could have something called uveitis. That's an inflammation of all three parts here. Okay? But we refer to it as the uvea. All right? And again, MUO is made up of. Okay? So, similar to what I just drew here, here's the layers. The outermost layer is the sclera, the white part. It continues up and below, and then it gets thin over here, and now this part of the sclera is now referred to as the cornea, very thin. The middle layer is the reddish area here, and I kind of drew that for you up there. That's going to be the choroid layer over here, gets thickened, and now this area is going to be the ciliary body. And it has these ligaments here that are going to attach to the lens to make that lens thicker and thinner. There is a thinner part that's going to extend in front of or anterior to the lens, and that's going to be the iris. These portions here are going to be the muscular layers. Okay? Now, like I said, it's not really a finger that comes out. You got to think three-dimensionally. It's going to be all the way around this. And I'll show you a picture so you can see it a little bit better. We also have the yellow layer here, which is the retina. And the retina is going to be filled with receptors to take in those light, or to take in that light so you can see what it is. And all those receptors are going to lead to the optic nerve that's back here. A couple other things that I'll mention later on, but I want you to see it here, is as the light, or the path of light goes through here, the opposite end, the 180 degrees of where the light's coming in, has a special name on the retina. It's called the macula. And this is the part that has the high acuity of focusing everything on it. Up here there's good focus, but here it's dead on. So this is the best focus, the best acuity that you could actually see things. You want the nerves over here to be perfect. And in there, it also indents a little bit, and that's called the fovea centralis, which is even more intense in terms of acuity. Okay? You'll see blood vessels come in here like this. Now, I just want to also mention to you something about the eye. The eye is the only place in the body where you can actually see the nerves. all right, you could see the optic nerve. It's the only place in the body that you could actually see it. This is the only place in the body that you could actually see blood vessels. All right? You could guess where they are in every part of else of your body, but here you're actually looking at the blood vessels. They're very thin, but if you're seeing that there's something wrong in the blood vessels, there's edema, there's some kind of leakage of fluid that's coming out there, you could bet if you see it here, it's a dipstick for the entire part of your body. So if you see something wrong with the nerve up there, something wrong with the blood vessels there, that's a sign that there's probably something wrong with blood vessels and nerves throughout the rest of your body. All right? And we usually do this constantly for people who have diabetes. Because diabetes, it affects the blood vessels, it affects the nerves. So I'm not saying, you know, an ophthalmologist is only used for diabetics. I'm just giving a good example that we, you know, when you're a diabetic, if you're a diabetic, and hopefully you're not, but if you are a diabetic or someone that you know has diabetes, they will be seeing their ophthalmologist at least once a year, and if there's any issues, they're going to be seeing them quite often, because this is the best way to give you an idea of the rest of the body. Okay? So this is kind of a three-dimensional thing, but you can see where the ciliary body is over here. It's going all the way around, and the ciliary body extends further, and then you got your iris. So don't think of it like the iris being just a finger over here. That's because we're doing a sagittal cut. You got to think three-dimensionally. It's going all the way around this. Okay? So it's kind of like, I like that picture because you could appreciate the three-dimensional look on that. Okay? All right, so the retina has all these photoreceptors on here, and there's two types. There's something called cones, and this is easy to memorize. They take care of color. Cones, color, right? And there's three types of cones. There's ones that detect red, another one that detects blue, and another one detects green. You would think that yellow, not green, but that's the way it is in our body. Okay? And then we also have rods, and this is sensitive to all light but not color. So these are going to kick on very well in the dark. Notice that if you're in the dark, you can't see color, but you can see shadows. You know what I'm saying? So this is good for that. And they call them cones and rods because of the way they look. And you can pick them out. These are rods over here. See how they're looking like rods? And here's, it looks like a cone. So that's how they come up with the names cones and rods. The blind spot. The blind spot is where the optic nerve enters or exits the eyeball itself. There are no cones and rods there. So you won't have any vision in that site. So what I'm trying to show you, if I go back to this picture here, you see where there's blood vessels here? There's no yellow there. The yellow is the retina that has photoreceptors. This is a part here that does not have photoreceptors. So technically, you're not going to get any kind of image on there. And both eyes have this, what we call blind spot. Okay? But you don't see, like, if you're looking at something, it's not like there's something blank over here. Does that make sense? Because the other eye is going to see that area. Like my blind spot, for my left eye, my blind spot is kind of like over here. All right? And my other one is over here. So my right eye is going to compensate with that blind spot over there. Does that make sense? Now you could actually find your blind spot because if you close one eye, you could actually find, I used to be able to do that, but I'll show you, there's a lot of techniques that you could actually see it. And I'll show you, I have a little thing up here you could actually do, but it's better if you're at a laptop in front of you. The macula, as I said, it's area that's 180 degrees on the opposite side of where the light is coming in of your pupil. The fovea is where that small depression is in the center of your macula. It has the greatest acuity there. There's only cones there. There's no rods there. Okay? So again, the light comes in here, and this is where your macula is. This is where you see the indentation, and that's where the fovea is also, okay?
So what macular degeneration is?
Right, and we're going to get into that too. You don't want to have macular degeneration occur because that's going to affect your best acuity, okay? Here's the blind spot again. Again, this is where blood vessels are coming out of, so we can't put nerves over there because blood vessels are coming out of it. So that's going to be our blind spot. Here's the optic nerve, okay? This is the thing, and I know the people on this side of the room won't be enjoying it, and that side of the room, but you two will, okay? And this is where something, if you do this at home, you'll be able to see your blind spot. If you follow those directions on there. The laptop actually does it a little bit better, and you keep your eye on there, and all of a sudden, what you're going to see when you follow these directions, you'll see this red dot go, and then about here it disappears, and then it comes back. So you'll see it on there. There's a lot of other things, like I've seen like pieces of paper that have a dot and an X, and you bring it close, you hold one, close one eye, you look at it, and then it disappears, and you come a little bit closer, it reappears. It's that kind of thing. So just giving you an idea of what the blind spot is, okay? Yeah, I don't think you guys will appreciate it as much because you have to be in front of it, okay? So again, here's the temporal side, here's the nasal side. So you're looking at the left eye, okay? And this is what you would see if a doctor or nurse practitioner or physician assistant is going to look in the eye. They're going to see this stuff in there, and it's going to give you, it's a little dipstick of your entire body when you're looking at the nerves and the blood vessels. You'll see over here, this is where your optic nerve is exiting, okay? You'll see blood vessels coming out of there. All right, they'll call it the optic disc. That's what they call it. It's the round area here, and you have the optic cup, which is more of the center area. But if you look closer to, let's say, the temporal area, you'll see an area that's pretty empty here, and you'll see a little concentrated area. You'll see the fovea. I'm going to show you pictures of what it actually looks like. This is just a schematic view. So the landmarks, like I mentioned to you, over here. And we have something called the fundus. Now the fundus is not exactly the same thing as a retina, but it's on the same line. You can't look at, when a doctor or a medical professional looks in the eye, you can't look at the entire retina because part of it is not seen, okay? So it's kind of like, the best way I could explain it is, if you want to look in it, and I'll put this over here so you can see this. All right. Let's say you're inside the eye. Here's outside, and a doctor is going to use an ophthalmoscope to look inside the eye, look at all that stuff that I just showed you on the board. Now he could look at, or she can look at the retina and see all the nerves over there, well not the nerves, but the retina itself, and can look all the way around. But the doctor or medical professional can't look here. I mean, I'm not going inside the eyeball, does that make sense? I can only see maybe 85%, I'm guessing, of the retina. I can't see portions that are over here. Does that make sense? All right, so that's what it is let me move this back. There you go. So the fundus is the part of the retina that the medical professional can see. There's a portion you just can't see because we can't get there. But it's a dipstick of your eyeball that we can actually say, well, if 85% looks good, the other 15% we're guessing is going to look good too. Does that make sense? So the fundus is the part of the retina that can be identified, okay? And we call that a fundoscopy. You're looking at the fundus itself, okay? So this is what it actually looks like. This is the right eye now, okay? So this is going to be where the nose is and the temporal area is there. So nasal area here, temporal area is over there. So here you're going to see the optic disc, and you see all these blood vessels coming out. You'll see over here the macula. It's not really showing, but there's usually, you see how like it's a little bit darker over here? It gets really dark in the center over there, and that's what we call the fovea, okay? So here, this is right and left eyes. There's the optic disc. There's the macula. You can see it's a little bit darker, and that's where the fovea is. You can see on both sides. Okay? Not too bad. Kind of neat. If you ever have to do this for your future careers, and you need to, this is a very difficult thing to do when you first get to do it, and it's, you've got to find a very obedient person to do this on, because you're shining a light in their eye, and they don't want to be there longer than 10 seconds, okay? But if you have an obedient dog, I did this when I was in medical school, and dogs, their pupils are huge. Even when it constricts, it's still pretty huge. I had a little Cocker Spaniel, and I gave her treats afterwards. I wasn't that cruel. But I put that up there. I did it for maybe like 20 seconds, I would think. And if they're docile enough, they're going to stay there. But I guess that's also like we shine a light to a deer. The deer will just freeze, you know. Kind of like if an alien came down and shone a light on us, we would freeze too, like, oh, where we're going, you know. But anyway, if you ever have to do that, you could practice on an animal. I wouldn't pick rabbits, but yeah, okay. Anyway, so that's what it will look like. Now, let's talk about the chambers, okay? The anterior chamber and the posterior chamber. The anterior chamber is a small area between the cornea and the iris. Okay, so we have, if the cornea, and I'll do it in white here. There's the sclera, cornea, sclera. Okay? So the anterior chamber is going to be located, here's the iris, and here's the cornea. So it's going to be this area here. Does that make sense? That's the anterior chamber. The posterior chamber is going to be posterior to the iris, this area over here. See the difference? Okay? This gets confusing because we're going to say chambers, and soon enough we're going to see cavities. There's anterior and posterior cavities, there's anterior and posterior chambers. Students find this very confusing, so I'm going to try and help you out with that. Alright? So again, these are chambers, and the iris is the dividing wall between the chambers. The aqueous humor. It's a watery liquid produced by the ciliary body. And it comes from here, and it's going to move around. We'll talk about that. It contains oxygen and nutrients. You see, there is no blood vessels in the lens, but that's tissue. Believe it or not, as hard as it is, it's tissue. And it needs oxygen and nutrients. Well, there's no blood vessels there. You wouldn't want blood vessels there because you will see blood vessels throughout your entire life. So how does it get its nutrients? Is simple diffusion. High oxygen over here, less over here, it gets diffused into the lens itself. We have something called the trabecular meshwork, and it's where the angle and the cornea, the angle of the cornea and iris meet. So there's going to be this angle, and I didn't really draw it to scale, but there's an angle that's over here and over here. And this angle is important, and we're going to deal with something called glaucoma. The canal Schlemm is a small opening in the sclera. I'll show you pictures of this. I don't want to draw it up over here, but you'll see a picture. And the way the circulation of this aqueous humor is, aqueous means watery, okay, is that it's going to go from the ciliary body into the posterior chamber, through the pupil, into the anterior chamber, through the trabecular meshwork, which is where this angle is, and right where the tip of this angle is where the canal Schlem is, and then there's blood vessels, there's veins and stuff, and that fluid is going to enter there. So you have this constant, let me see if I can use I'll use purple. You have this circulation that's going to go this way. Does that make sense? And same thing here. So it's going to fill in this whole area too. Right? I'll do this over here. So it'll just fill. Does that make sense? Okay? I don't have a video of this, so it's my video that I can do my animation. All right? So normally, very similar to the cerebral spinal fluid, normally, the rate that this aqueous humor is being made has to equal the rate that's going to get absorbed, right? If 100 milliliters is made here, 100 milliliters has to exit here. If 500 milliliters comes out of here, but only 100 milliliters comes out there, or exits it, that means there's an extra 400 that's happening there. You're going to have a buildup of fluid there. You're going to have a lot of pressure that's building up there. This is what we call glaucoma. Who here has heard of glaucoma? Right, always. Okay, this is what it is. So this is just a close-up of this area that I kind of drew for you, which is here. There's the ciliary body, makes the aqueous humor, goes into the posterior chamber, goes through the pupil, enters the anterior chamber, goes through the trabecular meshwork, into the canal Schlem, and goes into the bloodstream that way. So there's always a constant supply. It's very similar to, or analogous with the cerebral spinal fluid that we talked about before, okay? So here's where glaucoma is. The aqueous humor cannot circulate freely. For some reason, something's getting blocked. It's not that you're making a lot of the aqueous humor, it's just that it has problems exiting. And you're going to have this big buildup. So we're going to increase our intraocular pressure. And this could lead to blindness. It could press on things inside in terms of, let's say, blood vessels and stuff, and you're not going to be able to see. There's two types of glaucoma. There's something called open angle glaucoma. This is where the angle is still there. Something else is being blocked. Okay? This is painless, and this is the more common one. What happens here is that it loses peripheral vision. Okay? I'll show you pictures of this. Closed angle glaucoma, this one's rare and severe. This is the one that, you know, if this happens, we need to do something immediately. Otherwise, blindness is going to ensue, like, soon, in a matter of days. So the angle's too small and blocks the aqueous humor circulation. Okay? It's less common, more severe, very painful. You have blurred vision, photophobia. When light comes there, you got to close your eyes. You got to be in the dark. Okay? And it's that area here. That angle, you see the angle here, right? If that angle is compromised, that's where you got glaucoma. Okay? And this is what someone has with glaucoma. You see the peripheral vision is diminished. Okay? Questions about that? All right?
Glaucoma is actually a group of diseases. For now, let's talk about how our body maintains pressure in the eye. In our eye, we have three fluid-filled chambers. The fluid is clear in the front two chambers and is thick and jelly-like in the back chamber. Normally, this fluid is responsible for maintaining the pressure inside the eye and helps keep the shape of our eye intact. The fluid is generated in small glands near the muscles that control the lens in the middle chamber. The fluid drains out of the front chamber at the place where the iris, the colored part of our eye, meets the cornea, the clear protective coating. It drains in a tiny canal called the canal Schlemm. People with glaucoma have poor drainage and too much pressure in their eye. There are several ways that this can occur, but two examples we can discuss are when the sponge-like meshwork that filters the fluid becomes compact and prevents fluid from entering into the canal. Another way is when the iris is pushed forward and covers the canal. In either case, the fluid buildup in your eye creates pressure that pushes on the back of your eye and damages the optic nerve, which is the nerve responsible for transmitting images that you see to the brain. This pressure over time can cause blind spots and even blindness.
All right, now, what we talked about was, well, the posterior cavity. This is the anterior cavity, basically where the anterior and posterior chambers are. That's the anterior cavity. Does that make sense? The anterior cavity is divided into the anterior and posterior chambers. Make sense? All right, you see where chambers and cavities get confusing, okay? The posterior cavity is easy. It's this whole area. The lens is actually separating the two cavities. Inside the posterior cavity is what we call vitreous humor, not aqueous. Vitreous is more of a gelatinous substance, okay? So it's a clear gel-like substance, and it gives the shape of the eye. Eyes, if you've seen all the horror movies, they poke out the eye and you see this round thing. It's not round like a golf ball. It's more shaped like an egg, okay? And the reason why it is that way is because the way the light comes in and the lens comes in, you want it to be the focus of the picture or image that you're looking at. You want it to go on your retina. And if it was round, you're going to have things like, well, we'll talk about nearsightedness and farsightedness, but that's where that comes in. If the eyes are actually round, then it's going to be focused behind the eye. You want it to be on the eye, or at least on the retina. All right, does that make sense? When we get to it, you'll see. It's towards the end of this PowerPoint. So again, there's the iris, here's the lens.